Imagine stepping into the stable, and there's your horse, but something's clearly off. Instead of that smooth, sleek coat, you see these, well, bizarre raised patterns across their body. What might start as small, sort of distinct bumps can rapidly morph into sprawling, almost snake like, or even ring shaped plaques covering huge areas. Sometimes, the hair is just standing straight up over them, and if you press on them, they might even pit like soft dough. What looks like just a strange skin thing can actually be a sign of something far more profound, potentially even life threatening, particularly in breeds like, say, thoroughbreds and Arabians, who seem to have this surprising predisposition. These aren't just blemishes, they're conditions that can profoundly impact a horse's performance, their training, and really, their overall quality of life. Welcome to the deep dive. Today, we're plunging into the complex world of equine urticaria. You probably know it as hives, and its more dangerous counterpart, angioedema. Our mission here is to sort of unpack the stack of sources on these challenging conditions, giving you a shortcut to understanding what they are, why they happen, how they're diagnosed, and what it takes to manage them from, minor irritations right up to life-threatening emergencies. Okay, so that opening image, those bizarre patterns on a horse's coat that really screams urticaria. Let's dive into that first layer. What exactly are we looking at when a horse gets these characteristic hives?
Well, urticaria is defined by these distinctive wheals. Essentially, they're flat-topped bumps, papules, or nodules, usually sharply defined. They can range from just a few millimeters across to several centimeters in diameter, often standing a few millimeters high off the skin.
And that pitting you mentioned earlier when you press on them, that's key.
Yes, that's a hallmark diagnostic feature. It tells you there's fluid accumulating in the superficial layer of the skin, the dermis, that feels sort of doughy.
And the pictures you see online, they really show how varied these can look, right? Not just simple bumps.
Absolutely. The sources describe them as having remarkably diverse, even bizarre shapes. You might see serpiginous, that means snake-like patterns or linear streaks, arciform, which are curved, or annular ring-shaped patterns. And very often, these individual wheels will coalesce, they merge together into larger plaques that can cover quite broad areas of the body. And yes, the hair coat right over these areas often looks noticeably raised.
Where do they usually show up?
While they really can appear anywhere, you most frequently see them on the neck, the trunk, and the proximal extremities, sort of the upper parts of the limbs.
Now, when most people hear hives, they immediately think itchy. Is that always the case with horses? Or does it vary?
That's a really great question, and it's a critical point of variability. Some horses do itch intensely. They get really uncomfortable. They might rub, cause self-trauma, and that often leads to secondary bacterial infections.
Okay.
But here's the interesting bit. Other horses show absolutely no pruritus, no itching at all, even when the lesions look quite severe visually.
Huh. And how long do they usually last?
We tend to classify them based on duration. It's considered acute urticaria if the episode resolves within, say, 6 to 8 weeks. If it persists longer than that or keeps coming back intermittently, we call it chronic recurring urticaria. But to really get what's happening with urticaria, we need to look beneath the surface, right into the underlying inflammatory storm that actually triggers these wheals.
An inflammatory storm.
It all kicks off with the degranulation of mast cells. These are immune cells that are packed near blood vessels in the dermis. When they get activated, they rapidly release this whole complex array of potent chemical mediators.
So it's not just a surfacing, it's a deep cellular reaction. And these potent chemical mediators, are we just talking about histamine, the usual allergy culprit?
That's the common thought. But it's actually much more complex than just histamine. It really is an inflammatory storm. Histamine is definitely involved, but there's also a cascade of other powerful chemicals, things like platelet activating factor, various cytokines, heparin, prostaglandins, leukotrienes, the whole cocktail.
Wow, okay.
And this chemical cocktail causes vasodilation. The blood vessels widen, and critically, it increases the permeability of the local capillaries. Think of it like tiny blood vessels suddenly becoming leaky.
Right, like a sieve.
Exactly.
Right.
Fluid and plasma proteins leak out from the bloodstream into the surrounding dermis, and that's what forms the edema, the characteristic wheal or hive.
So it's not always a classic allergy then?
Well, a hypersensitivity reaction, which is IgE-mediated your classic allergy, is a common pathway, yes. But it's important to know that mast cells can also be directly stimulated by non-immunologic mechanisms. Things other than allergens can trigger them to release their contents.
That's interesting.
Yeah, so the key takeaway is that it's not just a simple histamine-only reaction.
Yeah.
And that has implications for treatment, right? Because it means just giving antihistamines might not always be enough to shut down the whole process, especially in more severe or chronic situations.
Right, that makes sense. So we've painted a picture of urticaria, the skin reaction, but the sources talk about this deeper and potentially far more dangerous condition,
Right.
angioedema. How is that different and why the extra concern?
Angioedema is distinct because the swelling involves deeper tissues. We're talking about the subcutaneous layer beneath the main skin layers and sometimes the submucosal tissues like under the lining of the mouth or throat.
And you said it's non-pitting.
Correct. Unlike urticaria's superficial edema, which pits when you press it, angioedema is characteristically non-pitting. The swelling feels firmer, more diffuse. That's a key differentiator.
And where does this deeper swelling tend to happen? I imagine swelling in certain places could be really problematic, especially for breathing or eating.
You're absolutely right to be concerned about location. The most critical sites are the face, particularly the lips, the muzzle, the area around the eyes, the periorbital region. Other common spots include the tongue, the oropharynx, the back of the mouth and throat, the larynx or voice box, the genitals, and the distal extremities like the lower legs.
Can it happen internally too?
Yes, it can, though less visibly. It can affect the gastrointestinal mucosa, the lining of the gut. And unlike urticaria, angioedema typically isn't itchy. Instead, horses might seem like they're experiencing a burning sensation or pain in the swollen areas.
Okay, so deeper, non-pitting, often painful swelling.
Exactly. And this brings us squarely to the most critical concern with angioedema, its potential to be life-threatening, especially when it affects the airway.
That sounds incredibly serious. What specifically makes it such an urgent medical emergency?
The major worry is its potential for rapid progression to life-threatening airway compromise. If you get severe edema, severe swelling of the larynx, the pharynx, or the tongue, it can quickly obstruct the airway.
Making it hard or impossible to breathe.
Precisely, leading to respiratory distress and potentially asphyxiation. This constitutes an immediate medical emergency requiring urgent veterinary intervention. No waiting around.
And the gut involvement.
Right. If angioedema affects the gastrointestinal mucosa, it can cause severe abdominal pain, which might look very similar to an acute surgical colic. Another emergency situation. Now, understanding why it happens is key for treatment. The pathophysiology, the mechanism, can follow two main biochemical pathways.
Okay.
One is histamine-mediated. This type is often seen alongside urticaria, the hives we talked about, and it generally responds well to emergency treatment with epinephrine, like an EpiPen.
Right, the standard allergy response.
Yes. But the other pathway is bradykinin-mediated. This type usually presents without urticaria or itching. It's often associated with deficiencies in something called C1 inhibitor. Think of it as a natural brake on certain inflammatory pathways, or it can be linked to the use of certain drugs, like ACE inhibitors, sometimes used for blood pressure.
And why is that distinction so important?
Because here's the crucial point. Epinephrine should not be administered for bradykinin-mediated angioedema. It simply won't work because it targets the histamine pathway, and it could potentially even be harmful.
Wow, okay, that's a critical difference for vets in an emergency.
Absolutely vital. It's a major clinical decision point. And interestingly, the triggers for angioedema often overlap with those for urticaria, the things like medications, insect bites or stings, certain foods, pollens, physical triggers like cold or pressure, stress, infection.
You get both at the same time?
You can. Angioedema occurs alongside urticaria in roughly half of cases, maybe around 49%. But it can also happen as an isolated condition, just a deep swelling, in about 11% of cases.
Okay, so given how varied these conditions are, how potentially serious angioedema is, and the different pathways, how on earth do you figure out the why? What causes a specific horse's reaction?
Well, that's the million-dollar question, isn't it? It's a significant diagnostic challenge. The causes, the etiology, are notably complex and often multifactorial. You might have immunologic triggers, non-immunologic ones, maybe an underlying infection playing a role. It can be a mix.
So not always straightforward?
Far from it. And what's particularly frustrating, both for owners and for us vets, is that a huge percentage of chronic cases, sources say up to 75%, end up being classified as idiopathic.
Idiopathic meaning?
Meaning the underlying cause simply remains unidentified, despite our best efforts.
75%. Wow, that's a daunting figure if you're an owner dealing with this repeatedly. With so many unknowns, where does a veterinarian even begin the diagnostic puzzle? How do you approach it systematically?
You start with what's widely considered the single most crucial tool in the whole diagnostic process, a meticulously detailed medical history.
Okay, digging deep into the details.
Absolutely. This history needs to be incredibly comprehensive.
Yeah.
We're talking about the age the horse first showed signs, the frequency of episodes, any seasonality, like does it only happen in summer, suggesting maybe insects or certain pollens. We need a complete, thorough review of everything the horse received: medications, vaccines, supplements, dewormers, especially within the 2 weeks before the lesions first appeared. Any recent environmental changes, new bedding, different pasture, new hay, diet modifications, all vital clues.
And the itching.
Yes, an accurate assessment of pruritus, how much itching, if any, is really important too.
So it really is like proper detective work. What about the physical exam itself? What specific clues does that provide beyond just seeing the hives or swelling?
During the physical exam, we're looking for those characteristic wheals that pit, or the non-pitting angioedema. We note their appearance usually acute onset, dome-shaped, multifocal, meaning in multiple spots. If the lesions are very localized, say just where the saddle sits, that might point towards a contact reaction, maybe something in the saddle pad, a grooming product, or the tack itself. We also assess the horse's overall attitude, their appetite, check for fever, any signs of systemic illness.
What about blood tests and things like that?
Right, systemic diagnostic tests definitely have a role. Blood work, a CBC, or a complete blood count, and a chemistry profile helps assess the horse's overall health. It can show signs of systemic inflammation or infection, like maybe an increased white blood cell count, or sometimes eosinophilia,
Eosinophils being.
a type of white blood cell often involved in allergic or parasitic reactions. Your analysis can be a useful general screening test, too.
But it's not just about finding inflammation, is it?
No, and this is critical. These tests, along with specific infectious disease testing, like for equine infectious anemia or equine viral arteritis, EVA, which can cause hives, along with other signs, serve a dual purpose. They help indicate inflammation, yes, but crucially, they help us rule out other underlying systemic diseases that might just happen to also present with skin lesions. Making that distinction is vital to avoid misdiagnosis.
Okay. Stepping back for a moment, you mentioned the challenge of finding the cause. This leads us to allergy testing, right? Which sounds like it could be a diagnostic minefield.
It absolutely can be. Identifying the specific allergen, if there is one, is often one of the biggest hurdles in managing these conditions long term. It's what we often call the diagnostic dilemma of allergy testing.
So, faced with that dilemma, what are the main allergy testing options available? And how reliable are they really in practice?
Okay, the first one often mentioned is intradermal skin testing, or IDT. For environmental allergens, things like pollens, molds, dust mites, insect components, IDT is generally considered the gold standard.
How does that work?
The procedure involves usually sedating the horse slightly, clipping a patch of skin, typically on the neck, and then making a series of very small, precise injections of various suspected allergens right into the skin. You then wait and observe for reactions, little bumps or wheals, at the injection sites after a specific time.
Sounds straightforward enough, but you said gold standard with maybe a hint of caution?
Well, yes, because while it's the best we have for environmental stuff, it's still an imperfect method. It can produce false positive reactions, meaning a reaction shows up even if the horse isn't truly allergic to that specific thing in real life. Plus, its usefulness for diagnosing food allergies is quite limited. And a major practical issue is that various medications, especially glucocorticoids like dexamethasone and even antihistamines, can suppress the skin reactions, interfering with the test results.
So you have to stop those meds beforehand.
Exactly, often requiring withdrawal periods of days or even weeks for some drugs before you can accurately perform the test. And interpreting the results correctly really requires specialized expertise. It's not just about seeing a bump.
Okay, so what about blood tests for allergies? They seem simpler, just draw some blood. Are they a better option?
Serum allergy testing, or SAT, involves analyzing a blood sample to look for allergen-specific IgE antibodies. IgE is the main antibody type involved in classic allergic reactions. However, these tests are generally considered less reliable than IET. They're known for being prone to high rates of both false positives and false negatives.
So they might say a horse is allergic when it isn't, or miss an allergy it actually has.
Precisely. Also, just finding elevated IgE levels in a horse's blood doesn't always correlate with clinical symptoms. Some horses have high IgE and are fine. Others have symptoms with lower levels. It's not a perfect match.
And I have to ask, because you hear about it sometimes. What about hair testing for allergies?
Yes. This is a critical point the sources emphasize. Hair shaft testing, which claims to detect allergies based on IgG antibodies in hair or through something called bioresonance, is definitively stated to be the least reliable method. It fundamentally lacks scientific backing.
So no good evidence for it.
Correct. There is absolutely no credible scientific evidence to support the use of hair testing or bioresonance for diagnosing allergies or any other medical condition in horses or any species, really. The rate of false positives and negatives is extremely high. It's essentially considered unproven and unreliable by the veterinary dermatology community.
That's a really important clarification for owners who might be offered those tests. Okay, so if IDT and blood tests have limitations and hair testing is out, how do you reliably diagnose a food allergy?
For suspected food allergies, the undisputed gold standard is a food elimination trial.
Which involves...
It involves strictly removing all suspected feed ingredients from the horse's diet for a significant period, usually at least 3 to 4 weeks, sometimes longer, up to 8 weeks. You typically switch to a very limited, novel ingredient diet, or sometimes just forage.
That sounds chill.
It is definitely time-consuming and requires huge owner commitment and meticulous attention to detail. No treats, no grazing on unknown pasture, strict control. If the horse's symptoms resolve during this elimination period, you then start reintroducing the original feed ingredients one at a time, usually waiting 1 to 2 weeks between each new introduction.
And watching for the hives to come back?
Exactly. If the symptoms reappear after reintroducing a specific ingredient, you've likely found your culprit. It's laborious, but it's the most accurate way to confirm a food allergy.
Are there other specific tests for less common triggers?
Yes. Briefly, there are specific challenge tests. For example, if you suspect cold-induced urticaria, which does happen, you might do an ice cube test, literally applying an ice cube to the skin for a few minutes to see if it triggers a wheal. Or, if exercise seemed to be the trigger, a controlled exercise challenge might be performed under veterinary supervision.
Okay. And what about a skin biopsy? When does that come into play in this whole diagnostic journey?
A skin biopsy isn't usually the first step for a typical acute case of hives. Its main role is as a valuable secondary or confirmatory tool. It's particularly useful in chronic, recurrent, or unusual-looking cases, or when you suspect something more than just simple hives might be going on, like an underlying systemic condition.
So it helps rule things out.
Yes, it's excellent for differentiation. It helps distinguish urticaria and angioedema from a whole range of other skin conditions that can sometimes look similar, things like bacterial infections, pyoderma, autoimmune diseases like pemphigus, fungal infections like dermatophytosis, reactions to things like snake bites, or even certain types of skin cancer, neoplasia.
So it gives you that microscopic view.
Exactly. It provides crucial histopathological information to help confirm the diagnosis and, importantly, rule out other, potentially more serious underlying pathologies.
Right. So let's say we've gone through all that detective work. We have a diagnosis, or at least a strong suspicion of what's going on. What's the game plan for treatment? Let's start with that scary scenario, severe angioedema.
Okay, first things first. Severe angioedema, especially if it involves the upper airways, is absolutely a life-threatening emergency. It demands immediate veterinary evaluation and intervention. Time is critical.
And the treatment depends on the type, right? Histamine versus bradykinin.
Precisely. For histamine-mediated reactions, the ones often seen with hives, likely allergic in nature, epinephrine is the recommended emergency treatment. It works quickly to counteract the effects of histamine.
But not for the other type.
Correct. As we discussed, if the angioedema is clearly identified or strongly suspected to be bradykinin-mediated, maybe the horse is on an ACE inhibitor or there are no hives present, then epinephrine should not be administered. It will be ineffective and could potentially cause harm. Treatment for that type is more complex and focuses on different pathways. Supportive care, like intravenous fluids, is often essential in severe cases, regardless of the cause.
Okay. Moving away from the immediate emergency, what about managing the symptoms day to day? I know corticosteroids are often used, but they always come with that big warning label in horses, don't they?
They do, and it's a very important consideration. Glucocorticoids, or corticosteroids, drugs like dexamethasone or prednisolone, are highly effective. They have potent anti-inflammatory properties and usually provide rapid relief from hives and swelling. Lesions often subside quickly. But the significant and critical concern in horses is the potential risk of inducing laminitis. This risk is thought to be higher in horses that are already predisposed. Think overweight horses, those with equine metabolic syndrome, EMS, insulin dysregulation, or pituitary pars intermedia dysfunction, BPID, or Cushing's.
Is the link definite?
While the direct causal evidence linking appropriate therapeutic doses of corticosteroids to laminitis in all horses is sometimes debated or considered weak by some researchers, the concern, especially in those predisposed individuals, is very real and taken very seriously by veterinarians.
Are there other side effects too?
Yes, other potential side effects can include gastric ulcers, potential kidney damage with high doses or prolonged use, suppression of the immune system making them more susceptible to infection, and in pregnant mares, there's a risk of abortion.
So it's a careful balancing act.
Absolutely. For these reasons, veterinarians often use them judiciously, perhaps short courses, tapering doses, or using the lowest effective dose, always weighing the benefits of controlling the inflammation against these significant potential risks.
What about antihistamines then? If the inflammatory storm is more than just histamine, how much help are they?
That's a good point. Antihistamines work by blocking the H1 receptors, preventing histamine from causing its effects like itching and swelling. Commonly used ones include hydroxyzine, pyrolamine, cetirizine. Newer second-generation antihistamines like olopatadine and levocetirizine have shown perhaps better efficacy in some studies. However, results can be mixed. Oral bioavailability, how much actually gets absorbed into the bloodstream, varies between drugs and between horses.
So they might not always work.
They might not provide complete resolution on their own, especially if other inflammatory mediators besides histamine are heavily involved. And symptoms can recur once the drug is metabolized and wears off. They are often used, sometimes long-term, but may need to be combined with other strategies.
Any other drug options?
Non-steroidal anti-inflammatory drugs, NSAIDs, like phenylbutazone, Buet, or flunixin-meglumin, Banamine, can help alleviate inflammation and any associated pain or discomfort. But again, long-term use carries risks, particularly gastric ulcers and kidney issues.
I remember reading about some newer therapies being researched.
Yes, there's some promising research into more targeted therapies. One example involves eosinophil targeting vaccines. The idea is to specifically reduce the number and activity of eosinophils, those white blood cells often involved in allergic inflammation, which might help prevent recurrent episodes in certain horses. Still largely experimental, but an interesting avenue.
Beyond pills and injections, are there simpler things owners can do for just symptomatic relief and general support, making the horse more comfortable?
Definitely. Simple things can make a difference. Cool rinses or cold hosing of the affected areas can provide good symptomatic relief by reducing heat and inflammation. Medicated shampoos, maybe containing oatmeal or bromoxine, can soothe itchy or irritated skin.
And supplement.
Supplements like omega-3 fatty acids from fish oil or flaxseed, and possibly MSM, methylsulfonylmethane, are often recommended. They have known anti-inflammatory properties and can help support skin health and potentially modulate the immune response, especially useful in chronic cases. So if we look at the bigger picture now, beyond just managing the flare-ups, the real key to long-term success often lies in either identifying and addressing the underlying cause, if possible, or finding ways to modify the horse's immune response over time.
That makes perfect sense. So if a trigger is identified through that detective work we talked about, what are the main long-term management strategies owners can implement? How do you avoid the problem?
Allergen avoidance is paramount if you know what you're dealing with. For environmental triggers like pollens, it might mean practical things like keeping the horse indoors during peak pollen times, maybe using HEPA filters and the stable ventilation if feasible. It also means maintaining really clean, well-ventilated, low-dust, stable environments. Using dust-free bedding, properly storing hay and feed to prevent dust and mold growth, these husbandry factors are huge.
And if it's insects?
Which is common, right?
Very common, especially conditions like culicoids, hypersensitivity, or sweet itch. If insects are the culprit, then rigorous fly control is absolutely essential. This means using effective repellents, fly masks, fly sheets, maybe restricting grazing during times of high insect activity, like dawn and dusk, using fans in stalls to create airflow insects don't like. It's a multi-pronged attack.
What about diet?
If a food allergy has been confirmed through that painstaking elimination diet, then the strategy is straightforward but requires diligence. Strictly avoiding the specific identified allergenic ingredients in the horse's diet moving forward. Reading feed labels becomes crucial.
And contact allergies.
Simple in principle. Discontinue using whatever offending topical product, piece of tack, or bedding material was identified as the cause. Sometimes requires some trial and error if it wasn't obvious initially.
Now, what about being more proactive rather than just avoiding things? You mentioned modifying the immune response. Is that where allergy shots come in? Exactly. That would be allergen-specific immunotherapy, or ESIT. You might hear it called allergy shots or desensitization. This is currently the only intervention available that actually aims to modify the horse's immune system, training it to become more tolerant to the specific allergens it reacts to, rather than just suppressing the symptoms.
How does ESIT work?
It involves the gradual administration of increasing amounts of the specific allergens to which the horse has tested positive, usually via IDT or sometimes SAT, despite its limitations. This is typically done through a series of subcutaneous injections given by the owner or vet on a regular schedule, or sometimes via daily drops administered under the tongue, sublingual immunotherapy or SLIT.
Does it work well?
Success rates vary, but the sources suggest beneficial responses, meaning improvement in symptoms are seen in a good percentage of horses, maybe around 70–88% for various allergic conditions, including skin and respiratory issues.
That sounds incredibly promising, actually trying to retrain the immune system. But you said it's the only intervention of its kind. What are the biggest real-world challenges or downsides for owners considering ACIT? Is it the commitment, the cost?
That's a critical point for owners to fully grasp before starting. ACIT is a significant long-term commitment. Allergies are generally considered incurable, so AC often requires lifelong treatment to maintain its effect.
Lifelong.
Often, yes. And it's not a quick fix. It can take many months, sometimes up to a year, for the maximum clinical benefit to become apparent. And if the therapy is stopped or interrupted, the allergy symptoms are highly likely to recur.
So patience and persistence are key.
Absolutely. Owners need to be thoroughly educated about the protocol, the long duration, this delayed onset of action, the need for consistent administration, and of course the expected costs involved over the long term.
And what about those horses, that big 75% where you never find the cause? The idiopathic cases, what's the approach then?
For that significant proportion of cases where a definitive cause remains elusive, management really focuses on controlling the symptoms as best as possible, using the medications and supportive care we've discussed. Rigorous environmental control, keeping things as clean and low allergen as possible, is still important, even without a known trigger. Nutritional support with things like omega-3s is also often part of the plan.
Any other angles for those tricky cases?
Sometimes, if psychogenic stress is suspected as a contributing factor, maybe in a horse that seems generally anxious or develops hives during stressful events, consulting with an animal behaviorist might offer additional insights or management strategies. It's about looking at the whole horse and their environment.
It really highlights the complexity. Thinking about everything we've covered, what stands out to you most? Maybe it is that sheer detective work involved in diagnosis, or perhaps the careful balance veterinarians have to constantly strike between using effective treatments like steroids and managing those potentially serious side effects like laminitis.
For me, it's probably the frustration of the idiopathic cases, coupled with the hope offered by things like ESIT. The fact that we still can't pinpoint the cause so often is tough, but having a tool that can actually modulate the immune system, even if it's a long commitment, is a major step forward compared to just managing symptoms indefinitely. And that critical distinction in treating angioedema based on the pathway histamine versus bradychalacin, that's a life-saving piece of knowledge.
Definitely. It leaves us with a lot to think about. So here's a final thought for you, our listeners, to mull over. Given the prevalence of these idiopathic cases where the cause remains unknown and the ongoing challenges in getting a precise diagnosis and finding perfect long-term management, how might continued research, perhaps into novel diagnostic methods or even more targeted therapies like those eosinophil targeting vaccines we touched on, potentially reshape the future for horses affected by these really complex and often frustrating conditions?